Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, we have a YouTube channel which you can access all the old and new videos which are uploaded. We also have a Telegram group. You can join this group to access all lecture related information. We have a Google Drive where the PDF of all lectures are available and a master integration key which coordinate between the PDF and the YouTube. These are the disclaimers. We are with phase 3, which is recorded pathology lectures. And today we have Pursue 1X, which is Uropathology. And the topic of the day is grossing to reporting of Wilms tumor. To talk on that, we have Dr. B. Vishal Rao, who is an MBBS, MD, DNB, PDF in Oncopathology from Tata Medical Center, Kolkata, diploma from Royal College of Pathology, UK. He's a fellow scientist as IARC editor for the WHO classification of urinary systems and male genital organs and pediatric pathology, the 5th edition. He has done his observership as Post Doctoral fellow at Johns Hopkins Hospital, USA. Presently, he is as a senior consultant pathologist and guide and course coordinator for the PDCC Uro-Oncopathology at the Department of Pathology and Lab Medicine at the famous Basavatarakam Indo American Cancer Hospital, Hyderabad. So I would request Dr. B. Vishal Rao to start his talk on grossing to reporting of Wilms tumor. Over to you, sir. Thank you so much.
Good afternoon, everybody, and good evening also. And today our topic of discussion is grossing and reporting of Wilms tumor. Wilms tumor. In Wilms tumor, not only reporting along with reporting clinical findings are also important, because on which type of treatment protocol the patient has undergone, according to that we have to do the reporting. So today we will see how to assess the entire Wilms tumor, the nephroblastomas, and see what are the different protocols and how we should report them, and what should we report them on, what is their significance, and what are the updates which are happening. So these are all the things we will try to see today. Okay, so as I told you, our topic is grossing to reporting of Wilms tumor. So this is my framework. So this is how I will go through my presentation, through introduction and the etiology, the pathogenesis, the clinical features, what is the role of a pathologist, the treatment protocol, which are very important, according to which we will try to report the case, and handling of the specimen, grossing, reporting, and the molecular updates which are happening, which will help us in cases where we are stuck. And I'll give example of the cases in each protocol and conclusion. So before going to introduction, let's have a preview. Let's know this man, the German surgeon and pathologist Max Wilms, who coined the term this Wilms tumor, and first described in 1899. And pediatric renal carcinomas are rare and account for 2 to 4% of renal neoplasms in childhood and adolescence. The most common include nephroblastoma or the Wilms tumor, which is comprising 85%, and other are mesonephric nephroma, clear cell sarcomas of kidney, rhabdoid tumors of kidney, and miscellaneous tumors. We will see most of the tumor today in our presentation. Coming to introduction, Wilms tumor, as we know, is the most common primary tumor in childhood, and it accounts more than 90% of the malignant kidneys tumor, diagnosed in children aged 7 years or less. And the incidence of RCC starts to increase in older children, but nephroblastoma or Wilms tumor is still more common type to the age of 13 years and constitute 23% of all RCCs diagnosed patient age 15 to 19 years. And there is an increase in these pediatric RCC due to obesity, dietary habits, and better better imaging techniques. Wilms tumor is, as I told you, most commonly seen in 3 to 4 years of age, and there is a slight female preponderance also, as compared to the adult RCCs where male predominance is there. And majority of nephroblastoma cases are non-syndromic, but 10 to 15% of children it is associated with syndromes and congenital anomalies. And in 1 to 2% it is familiar. The management and assessment of Wilms tumor depend on protocols used and followed by the histological diagnosis and their stage. So before going to those protocols, first let's understand what is the etiology of nephroblastomas and what are the precursor lesions. They are thought to the nephrogenic rests are thought to be the precursor lesion because they are found 40% in unilateral cases and more than 90% in bilateral cases. And a number of genes are implicated in its development, including the WT1 is the most common gene at chromosome 11p13 and other unidentified genes. We'll see later part of the presentation. And it is still not clear how the nephrogenic rest progress to the tumor, as you can see. These rests. And this is a model which is a little bit old, but still holds good. And where we can see that there is a 16q loss and anaplasia, which are probably the late events, and they are independent of each other. And p53 abnormalities and anaplasia appears related. And it is possible that there may be no rest stage in development of in some tumors also. So, and coming to the pathogenesis still incompletely, we cannot say completely, but incompletely understood, where we can see that so where you can see that there are the sporadic tumors which comprise more than 90% have beta-catenin and p53 mutations, and then there is a microRNA processing is there. Mutation is there, and which causes an impaired epithelial mesenchymal to EMT transmission, and then there are persistent blastomal rests, and they are which leads to increased chances of carcinoma, the contralateral kidney tumors. And in syndromic also different, there is a WT1 loss function is there, which leads to these syndromes also. So mostly they develop in the kidney, but there are some tumors which they are outside also. They develop outside also. They are well circumscribed margin and tan to gray in color. Clinical features usually patient present by asymptomatic abdominal mass. This is one of our patient who presented. The parents or the caretakers will give a history of this mass, and then there will be a gross hematuria, abdominal pain, hypertension, and anemia will be the clinical features. And imaging wise, ultrasound is one of the study of choice because it confirms the presence of renal mass without any radiation, and it helps in the preliminary assessment of the contralateral kidney, presence of metastatic disease, presence of tumor thrombus also. However, imaging techniques like MRI and CT scans are also used for diagnosis and proper staging of the tumors, and chest CT can be used for metastatic assessment. What is the role of pathologist? The role of pathologist in Wilms tumor is diagnosis primarily, and then to identify the histological subtype, the risk group, and make a precise evaluation of the stage of the tumor, which will have the further help in the treatment of the patient. And even in children with stage 4 disease, local staging is critical to determine the utilization of radiotherapy, whether the thrombus is removed or not. So based on the correlation between the histological features and survival, 3 prognostic groups of typical renal tumors of childhood were discerned in some SIOP trials and studies. So what is SIOP? We'll find out here. So what are the treatment options in Wilms tumor? So surgery, chemotherapy, radiotherapy are the treatment options in Wilms tumor. And there are 2 treatment protocols worldwide which are used. So the SIP protocol, which is mostly used in Europe, Middle East, and Asian part of the country, and Children's Oncology Group, which is used in the US. So both because of the difference in they have the treatment philosophy, the staging system is a little bit different, and we'll see what it is. So SIP is basically if the patient receives chemotherapy first, followed by surgery. In children or COG protocol, the patient undergoes upfront surgery followed by chemotherapy. So both the protocols recommend immediate nephrectomy without preceding chemotherapy in first 3 months of life. The incidence of because of these tumors like rhabdoid and mesoblastic nephromas increases. So that is why upfront surgery is required. However, there are some recommendation by the SOIP team about the pre-chemotherapy biopsy. One is only for patient aged 10 years or older, patient between 7 to 10 years with smaller tumors, and in some rare indicated cases as defined, which are like unexpected age range, radiological atypical characteristics, and poor chemotherapy response. In COG protocols, it allows histological classification into broad two classification. So one is favorable, where there is no anaplasia, and versus unfavorable. Another is a histological anaplasia, where it is focal or diffuse. We will see all these in our PPT later. And for complete staging based on COG protocol, the extension outside the kidneys, these are the points which are required: invasion of the vessels or perinephric tissue, or presence of lymph node with metastatic disease. What are the exceptions for the COG, where chemotherapy has to be given in the COG protocol, which they don't give? Whenever there is a tumor thrombus which is extending above the level of hepatic vein, gross involvement of contagious structures, and bilateral Wilms tumor, extensive pulmonary compromise is there because of a massive tumor, and to avoid significant morbidity. So this is the staging. I'll be going through the staging individually also, but just to give you a comparison, you can see it at your ease later also, that the stage 1 to 5 stage, where stage 1 is limited to the kidney and stage 5 is bilateral renal involvement. And more or less, they have similar extensions and all. So we will see when we see we'll see individual cases. So what are the advantage of SIOP protocol when they want to say that? Because advantage of SIOP protocol is it gives us a favorable tumor stage distribution, because tumor gets is shrunken, and it gives a favorable tumor stage, and reduce the risk of tumor rupture also, because the tumor has shrunken, decrease the risk of hemorrhage, and reduces tumor size and formation of a fibrous pseudo capsule that facilitate surgical removal easily. But however, what are the disadvantages in SIOP protocol where you have to give chemotherapy? First is there is a loss of staging information, because if or eradicating of the neoplastic cells if the tumor cells are not there from the lymph node, so staging will be lost. Then treatment of a benign condition with chemotherapy, if we don't know, with our prior biopsy is not there and we are treating it as a tumor, if it is a benign, then over treatment will be there. And then initiating treatment of a different malignant disease with a potentially inappropriate chemotherapy, whether it is a different type of tumor, and chemotherapy is given for the Wilms tumor, and tumor growth during treatment if it is not responding, and rupture while giving chemotherapy can also occur, which is waiting for the surgery. However, in the COG group, advantage is that it provides a detailed histological staging, and also there is accurate molecular DNA based studies, and that is loss of heterogeneity test, which is necessary for planning post-operative treatment. The disadvantage is whenever there is an unresectable tumor or a spillage or a hemorrhage or a bilateral tumor, in those cases, the upfront surgery is difficult. So where these two protocols meet, the survival rate for both the strategies are similar, and while taking surgical removal, pre and post chemotherapy and radiotherapy into consideration, so survival rates are similar in both the protocols, and both these protocols are focusing on minimizing the side effect, late effects of the treatment without compromising the current excellent overall survival rates, which are very more than 90%. And in addition, both cooperative groups are in search of a better treatment options for patients and adverse features and suboptimal survival rules. So a word about chemotherapy. You should know about this thing also, because in both the protocols, chemotherapy can be used. So stage 1 and 2 with favorable histology, vincristine and dactinomycin are used, and in higher stage 3 and 4 with favorable histology, doxorubicin is added in COG. However, SIOP does not recommend addition of doxorubicin for stage 3 favorable, intermediate or low risk tumors. In advanced stages of 2, 3, and 4 of tumor with anaplasia or high risk tumors, other drugs are added along with radiotherapy. And stage 4, 5, where bilateral tumors are there, preoperative chemotherapy is given along with this doxorubicin, and followed by a nephron sparing surgery. So what type of surgery is done? Current standard is unilateral Wilms tumor is transperitoneal radical nephrectomy is done with ipsilateral lymph node sampling. And although extensive lymphadenectomy is not required, but perihilar, periaortic, or paracaval node sample must be combined in all cases, as they are necessary for adequate staging and planning of the post-operative management. So, and what about the treatment of bilateral Wilms tumors? So, bilateral tumors will undergo neoadjuvant chemotherapy, which is recommended in both the protocols for 6 to 12 weeks, and chemotherapy is dictated by individual response. With the tumor reimaging and an assessment is done after the second cycle of chemotherapy. And possible alternative bilateral partial nephrectomy can be done, or a unilateral radical nephrectomy and contralateral partial nephrectomy, depending upon the size of tumor in each technique can be done. And most cases are amenable for nephron sparing surgeries. And minimal invasive surgeries should be done at a center with experience, because sometimes it is difficult to obtain a negative margin, which can be sent for frozen section to us also, and which will lead to risk of local recurrence and adverse impact survival and demand therapy. And nephron sparing surgery is done to decrease the risk of renal failures, and it is associated with smaller bilateral tumor with omission of lymphadenectomy. And despite lymph node understaging, overall survival was similar in both the nephron sparing surgery and radical nephrectomy. This is one of our case, which is partial nephrectomy, where you can see this is the raw surface and this is the tumor which is bulging, and we should ink this surface, and then we should take a perpendicular section for proper assessment of the tumor. So how we handle the Wilms tumor specimen? First, we will see how we handle in SIOP treatment protocol. So before our specimen, when the specimen comes to our department, so what should you do is these are the information which you required. What is the patient age, and what is the procedure has been done, what is the tumor site, and what are the pre-operative biopsy performed or pre-operative chemotherapy, what are the treatment protocol, whether it is under SIOP or COG protocol. And information regarding distance metastasis, you can look into imaging, whether patient has undergone CCT or the other imaging has been done or not. So clinical details should be include information regarding the pre and intraoperative rupture if anything is there. Ideally, the surgeon should mark the site. So again, you have to ink it in a different color wherever there is a rupture, and you should ink the other area in a different color. All these elements are required to accurate assessment of the tumor stage. So staging, as I told you, SIP stage 1 is limited to the kidney. Stage 2, again, viable tumor is there in the perinephric fat, but it is removed completely. Stage 3, again, it is like an R1 or R2 resection, where there is a viable tumor present at the resected margin, and abdominal lymph nodes are there, and pre and intraoperative tumor rupture has occurred. So you have the information should have been given. So you should note this information in your forms, and then it automatically upstage the tumor to stage 2, 3. And stage 4 is hematogenous metastasis or lymph node metastasis. So again, liver and lung are the most common site. We will see again. And stage 5, as I told you, bilateral renal involvement will be there. So reporting in a biopsy, the main purpose of biopsy is to establish whether usually biopsy is not done, as I told you in both the protocols, biopsy, how they are done. And main purpose of biopsy is to establish whether the tumor is Wilms or not, or any other renal tumor, and that may require different pre-operative treatment. So, but frozen section should not be done. Frozen section diagnosis is not appropriate also, and if there is only one component also, it will be difficult. So it is not recommended Wilms tumor. So how you prepare the specimen? So before you receive the specimen intact, should be intact, present in when it is received, it should be intactly received by the pathologist, and it should be fresh, unfixed in the laboratory. And then the specimen must be transferred promptly to the lab with to enable snap freezing for the molecular testing also. So how to handle the specimen in block sectioning? So the whole specimen should be weighed, measured, and photographed. And the photography allows us to discuss in MDTs and facilitate central pathological, if you want to take a review also with regard to sample site interpretation with the surgeon or with the fellow pathologist. And any areas of rupture or fissure, as I told you, should be inked in different colors from the rest, so it will automatically upstage the tumor. And the specimen should not be decapsulated, as this may make a determination of growth beyond the capsule impossible. And so this is how you, after fixation, while fixating, you have to take a whole section as a specimen, the surface of the whole specimen. Areas with the excitement are possibly and renal sinus should be inked, and they should be allowed to dry. And this is a critical step. Without inking, it might be impossible to stage the tumor correctly. The specimen should be opened with a longitudinal incision to bivalve, and it should be opened like this. And the cut surface should be also photographed for the extent of necrosis and multicystic, if any multicystic areas are present. And you can give a serial sections to the specimen also for better fixation. Any other variegated area also. After fixation, it looks like this. And before further fixating, the sampling for molecular biology studies should also be taken at that moment only, at least 2 pieces from the different part of the tumor, or if a prior biopsy, that should also be taken into account. And a mirror sample of the tumor adjacent to the frozen sample should also be fixed in formalin and studied for histology, and then it can be accompany the frozen tissue for that. And adjacent kidney also 2 pieces should be taken. If later on a sample of nephrogenic rest, if they're identified, it should also be taken. 10 ml of peripheral blood in EDTA should be taken, and all samples should be stored at -70 degrees under liquid nitrogen for transport, and everything should the time should not exceed more than 60 minutes. So 30 to 60 minutes is the time. So how will you do the grossing? So this is the after fixation. This is one of our cases. So after the fixation of grossing, you can see that these are usually large solitary cervical masses. They are sharply demarcated by the renal parenchyma and distorting the kidney contour, as you can see in this case, where it is involving the upper pole and the mid part of the kidney. And in about 10% of cases, there are multifocal also. And in cases there are underground primaries of the tumor is gray, white to gray, pink gray in color, and lobulated, soft, and friable. Depending upon if it is a post-treatment case, depending upon the areas of necrosis, and you have to assess whether there are areas of necrosis, and then you have to do gross accordingly. In nephroblastoma treated with preoperative chemotherapy, necrosis and hemorrhage are usually extensive. And some tumors may have a prominent cystic appearance also. So grossing of Wilms tumor specimen, the specimen should be fixed in 10% buffered formalin for 24 to 48 hours, and accordingly several other cuts should be made, as I told you, to initiate better fixation. And block section should be photographs or a pre-prepared diagram, like you can make a diagram like this, and the sample for histological exam should include at least 1 longitudinal slice of the tumor and completely sampled. So this is another one of our recent case, where you can see an exophatic mass at the middle part of the kidney. So again, you have to, and this patient received uh, chemotherapy before the surgery. So we have already tried to grid it, take the entire section and try to grid it and give it accordingly. So as I told you, in this case, the entire section was cut and it was grading was done, and this is how you give all the section A, B, C, D, E, F. You have to label it and give the sections. So entire tumor section is cut, grading done and submitted entirely. So in addition, following should be sampled. Any different areas are there grossly. If you find percentage of necrosis or regression changes or go on gross examination, and areas suspected of being completely resected or surgically adherent, which are marked by the surgeon, and renal sinus involvement, lymph node involvement, and renal pelvic fat, ureter vessels involvement should be there. And tumor kidney interface and capsule should also be included. So area of the capsule, of the areas of the perinephric fat, areas of adhesions, normal kidney and block guide should always be there. So after handling the specimen grossing, now how will you report the cases of Wilms tumor? So as per SIOP guidelines and RCPath datasets, there are some core elements and there are some non-core elements, items which have to be reported. So the core data items include the specimen integrity, renal capsule integrity, weight, specimen size, location of the tumor, focality, and tumor size in all three dimensions. The non-core data items are the presence of associated anomalies are there or not, microscopic assessment of the percentage of epithelial and stromal component more in SIP, and presence and absence of nephrogenic rest, and coexisting pathological changes and ancillary studies done. So this is the histology, and histology of Wilms tumor consists of three component or patterns. So one is the epithelial blastomal component, the epithelial component, and the stromal component. In this, you can see all the three components. The epithelial component is this one with tubules and glomeruli type, and the blastomal component in diffuse sheets, and stromal component in loose sedimented stroma. Now we will see individually how the blastomal components is. It is the least differentiated component, and the tumor cells are in diffuse sheets and nests. And as you can see, they are small to medium size undifferentiated cells, relatively small regular nuclei is there, and very small nuclei is present. So this is the blastomal component. The epithelial component, as I told you, have well differentiated element, which include glomerular-like structures, as you can see here. Glomerular structures are there, and small tubules can be there, and moderately will have tubules and papillary structures, and poorly will have rosette-like structures. Mesenchymal component, the stromal component may show variable appearance like hypocellular, I showed you before, and hypercellular in this, and undifferentiated areas can be there, and there can be heterologous elements also like cartilage, adipose tissue, or rhabdomyoblast. So another important point to report is anaplasia. What is anaplasia? Whenever you see cells with marked nuclear enlargement and hypochromasia, it is called as anaplasia, and there is presence of also along with that there is presence of enlarged atypical tripolar or multipolar mitosis, as you can see here. One is there, and it is found in 7 to 10% of nephroblastomas, and they are subclassified as focal and diffuse anaplasia. So what is focal? So focal, there is a clearly delineated focus within the primary intrarenal tumors. So in COG, you need to have 4 foci to say that it is focal, at least. And in SIOP, 2 foci of more than less than or equal to 15 millimeter are enough to call it as focal. And if more than that, you will call it as non-focal or diffuse. So diffuse anaplasia is non-localized anaplasia. Focal ones with marked nuclear unrest in the remaining tumor anaplasia beyond the tumor capsule, and anaplastic cells in intrarenal and extrarenal vessels and renal sinus and extracapsular sites, and metastatic deposits, anaplasia, and biopsies. So what is the importance of these is that the nephroblastomas with diffuse anaplasia show a different age distribution usually than the non-anaplastic one. The former, like the former, are extremely rare in the first year. So diffuse anaplasia is rare in first year, and and rare in second year. However, they are seen more than half of the patients with more than 4 years of presentation. So these are the heterologous elements like chondrite. These are one of our cases, and these are the treatment-related changes. As you can see, the pigmented hyalinization is there, and macrophages are there, and in this there is a necrosis. You have to percentage the necrosis also. So the mesenchymal component is there, as you can see, and some treatment-related changes are there. This is the epithelial and mesenchymal components are there, which are infiltrating the renal sinus fat. And this is a photomicrograph of tumor with normal kidney interface. And this is treatment-related changes. As you can see, there are many pigment-laden macrophages and lymphocytes. Inflammation is there. And you can see other treatment-related changes like phomeostocytes are also there. Other component is nephrogenic rest, which are thought to be the precursor lesions, which are found in, as we've seen, 40% in unilateral and 90% in bilateral tumors. So they can be perilobular, which showing a sclerosing in hyperplastic rest, and they can be intralobular nephrogen mingling with the normal parenchyma can also be there, and also perilobular the hyperplastic nephroblastosis can also be there. So what are the diagnostic point? So because there are three components, so when will you call what are the essential criteria to call it as a Wilms tumor? So presence of two or more component of blastomal, epithelial, and or stromal are essential for diagnosis of histopathology. And monophasic nephroblastoma is a difficulty, because if only one component is seen, we have to differentiate it with other tumors, and ISC and molecular testing are required at that time. And diagnostic staging also, tumor staging is also very important for therapeutic and prognostic criteria for renal tumors. And accuracy of the staging still represent a major problem, because very large tumors of nephrectomy are there, and difficulty to assess their relationship with the normal parenchyma can be there with the capsule or renal sinus. So renal sinus, as you can see, you can identify when there is a nerve and then there are thickened blood vessels are there, then you can identify that this is a renal sinus. Staging also in SIP and COG, both the protocol different, they have different staging, and they still have some differences related to the initial treatment of nephroblastomas, and staging is done on the basis of findings recognized at the time of nephrectomy. Pre-treatment FNAC or true cut biopsy is not a criteria for upstaging in SIOP, and in COG only on any biopsy result in stage 3. So that is why we should know that there is pre-treatment biopsy has been done or not. So this is a thrombus, as you can see. Thrombus is in a treated case of this Wilms tumor, where you can see a small epithelial component is there, and thrombus is there in the renal vein. So what is after grossing reporting, what are the prognostic significance of this reporting? So these are the points which you have been seeing in SIP: presence of percentage of viable tumor, blastema, anaplasia, necrosis, perirenal fat, renal sinus invasion, and renal vein invasion. So as you can see, most of them are have a prognostic significance, and anaplasia definitely have a risk stratification effect in the risk stratification group, and most of them give important prognostic information in staging. Lymph node examination is very important. For example, and you should mention that lymph nodes were sent or not, and if what are the groups which were there, and the number of lymph node identified, number of the nodes positive or negative, tumor involvement, whether it is viable tumor or non-viable tumor, and lymph node involvement is also an important prognostic information in SIP staging. So this is the performer from the RCPath datasets you can see. So these are the information you have to collect, the gross and the preclinical details which I told you, clinical details and my gross findings, and then this is the histological findings. What are the percentage of the viable tumor, blastomal percentage, and where the extension of the tumor is there, and depending on the lymph node, number of lymph node seen, and number of lymph node positive, and whether positive, whether viable, non-viable, or both. So what are the caution? As I told you, FNAC does not upstage the tumor and COG. And if the presence of necrotic tumor or chemotherapy-induced change in the renal sinus is there, or renal vein, or within the perinephric fat, it should not be recorded as a reason for upgrading the tumor. And the viable tumor infiltration of fat between kidney and adrenal or of the adrenal system does not upstage the tumor if tumor is contained within the pseudocapsule. And presence of viable tumor in lymphatic or blood vessel in this area is regarded as stage 2 only. Liver tumor, the tumor might be affecting the liver capsule, and this should not be regarded as infiltration in the adjacent organ. Only if clear infiltration is present, then it should be upstages. So after the SIOP protocol, we'll see the CAP protocol, which is where they use the COG treatment protocol, where upfront surgery is done. So there are many issues that can interfere with making accurate diagnosis and staging in handling. And again, here also frozen section should be avoided. And molecular, before taking for the routine section, molecular sections for molecular studies should be taken, like viable tumor, portion of the non-neoplastic kidney. The latter serves as a useful control. Non-neoplastic kidney serves as a useful control in molecular genetics, and nephrogenic should be sampled and frozen for the same reason. So this is a recent case which is of a 6-year-old boy, and he didn't receive any treatment, and upfront surgery was done because it was a very localized tumor. Here you can see it is mostly present in the upper pole of the kidney. And what you have to take is tumor. These are the tumor section 3 to 4 non-necrotic areas. You have to see, give a section with tumor with capsule, perinephric fat, and gyrotous fascia. Then again, tumor with renal sinus fat, hilum, and adjacent normal kidney should be given. And then the cut margins of renal artery, vein, and ureter should be given. And any other areas. And morphology will be same because we have the triphasic pattern, blastomal, consisting of the blastomal, epithelial, and stromal elements. What are the histological risk stratification classification in for Wilms tumor? For SIOP, low risk is cystically partially differentiated nymphoblastomas, completely necrotic are considered low risk. And similarly in COG also, intermediate risk, again, epithelial, stromal, or mixed elements are seen on focal aneuplosia. However, in COG, it is favorable histology where there is no aneuplosia. Wilms tumor, no evidence of aneuplosia, should be intermediate risk. In high risk cases, diffuse aneuplosia and blastomal types are there. And in COG protocol, diffuse and focal aneuplosia, both are considered as high risk case. So staging, again, there are many staging system of AJCC, UICC, TNM staging, but we don't have to use that. We have to use the COG staging system there, and this is a staging system. It is available in CAP protocol also. You can go through it. So basically, as I told you before, the stage 1 consists of the tumor which is limited to kidney and completely resected. And stage 2 is viable tumor extent beyond the cut, but is completely resected with the negative margin. And stage 3 is non-hematogenic metastasis confined to abdomen. Tumor in the regional lymph node should be considered in this. And any rupture, spillage before the surgery or piecemeal excision of the tumor should be included in this stage. And again, stage 4 and 5 remains the same, like hematogenous metastasis or lymph node metastasis, and 5 is bilateral renal. So recently, we have published our paper in the January 1st quarter of this year in urology annals on grossing and reporting, and we have studied the Wilms tumors in our institute, and we saw that COG with a higher stage had higher risk of recurrence was seen in other studies, but in our study we didn't find that thing. And when we compared the outcomes of in both the treatment protocols, we found a very good overall survival of 96% in SIP protocol and 90% in COG protocol. So what is the problem? With now you have grossed, you have report, you have prognosticated. Is there still a problem? Yes, there are some practical problems. So practical problems can arise in a biopsy or in the resection specimen itself. So in biopsy, what is the problem? If you only one component is seen, either blastomal component is seen, then you have differentials of neuroblastomas and other beak or tumors. So again, if only necrosis have come, you cannot comment on the what type of tumor it is. If there are no non-viable epithelial tumor cells are not there, no viable epithelial tumor cells are not there, and if tumors with morphologically overlaps are there, then it is a problem. In resection specimen in SIP, if only necrosis is seen, so definitely you have to gross more in those cases. And grossly staging becomes difficult, because the boundaries are lost post treatment, so difficult to the treatment, the staging is difficult. In COG protocol, if tumor is locally advanced and if areas of necrosis are there, then there is a practical problem in these protocols. So whenever you have a problem while reporting in a small biopsy or large, you have to see the age, the associated syndromes, presence and pattern of metastasis. IARC can help you in those cases, and molecular testing also can help you. And needle biopsy, when indicated, should be performed using a percutaneous needle approach. It is going to use a coaxial technique under image guidance to avoid areas of necrosis. So image guiding multiple cores can also be obtained for better yield and diagnosis. IARC can be used in cases where there is only one component is there, but is it a savior, or it adds to more confusion? As you know, WT1 is the most sensitive and specific marker which nuclear staining is there in more than 90%, approximately 90% of cases, with antibody directive around the C and N terminal of the WT1 protein. And since we have 3 components, and every component will show different IARC profile also, like plastimal will show WT1 taxate, vimentin, and CD56 can be there in variable staining. And in epithelial components, cytokeratin, EMA, CD56 can also be there. And stromal component, vimentin can be there, and WT1 can also be positive, weak, or absent. So what are the differential diagnoses? So first is a metanephric neoplasm, which are benign neoplasm, blunt renal neoplasm, and they resemble the components of where only if you get epithelial component. So it will be showing as that like that, and these lesions are benign, and although they may really coexist, and they can coexist with Wilms tumor and papillary RCCs also. And the pathologic spectrum includes adenomas, stromal tumors, and adenofibromas. So if we have one component of mesenchymal or epithelial, or 2 components of epithelial mesenchymal, then this becomes a DD. And these neoplasm composed of cuboidal cells with primitive basophilic nuclei, and minimal cytoplasm will be there. As you can see, the tubules are there, and all these tumors are BRAF mutation is there in all these tumors. So other differential is nephroblastoma, is neuroblastoma, and definitely we face a problem in day-to-day when we receive the biopsy, and when in a biopsy WT1 is negative and CD56 is positive. So CD56 can be positive in neuroblastoma and can be positive in nephroblastoma. So how will you go about it? So then you have to see the clinical picture. How is the clinical picture? So neuroblastoma, again, it will be associated with opsoclonus, myoclonus syndromes. You have to see, as I told you, what is the age of the patient, what are the symptoms associated, whether it is crossing midline. So these tumors usually cross the midline and usually fixed, and they are immobile, and they are in Wilms tumor, as you know, those syndromes are there, and they do not cross the midline and may be displaced, and the constitutional symptoms are not common. And as you can see, more of calcification will be there. And another slide I have where differentiation, you can see that they have some features. These are the constitutional features. And then calcification is there. Calcification is there in this. So now this is a recent case we got in our lab. This is a tumor which is attached to the kidney, and this is the tumor. As you can see, this is a gray white tumor with lot of areas of calcification, which you can see in the microscopy also. Calcification, and there a sheet of it, these cells are there. So already this case was diagnosed on biopsy, and because of the clinical picture, this was diagnosed as neuroblastoma. And lymph nodes were also positive in this case. So other tumors which are differentials are the congenital mesoblastic nephroma, and it can be classic where it resembles fibromatosis, and it can be cellular also. And the classic type is harbor EGFR active mutation, and the cellular harbors the ATV6 and NTRK gene fusion. And so as you can see that they are cellular type, they usually have this dense plump cells of sheets, or they may have this interlacing fascicles of spindle cells can be there. So if only one component is there, it becomes difficult and becomes a differential. Clear cell sarcoma is again a BCOR internal tendon duplication is seen. We can detect by NGS, and so whenever there is a stromal there is a only blastomal component is there, then these tumor can be difficult to diagnose, differentiate also. Where there is a spindle cell, you can see sarcoma differentiation and anaplasia also. So in these cases, it may be difficult. So again, ISC can help you on the cyclin D1 and BCOR will be positive, nuclear diffuse strong positivity, you can see. Other tumors, rhabdoid tumor also, both renal and extrarenal, these have that SMARCB1 gene mutation is there. And germline mutation has been identified in this. And as you can see that there are diffuse growth pattern of these tumor cells there. So it may confuse with the blastomal type. And prominent nucleoli will be there, and cytoplasmic inclusions can be there. And there is in the ISC, you can see the INN1 loss will be there. Expression will be lost in the tumor cells. Syndromes associated with the Wilms tumor, when you will suspect, whenever there is a bilateral tumor affect approximately 5% of the children, and syndrome should be suspected when there is a presence of bilateral tumor and Wilms tumor, and multifocal tumors are there, recurrent tumors are there, and earlier age of onset is there. So then you have to suspect a syndrome associated. And this is the list of the syndromes, and you must have heard many Beckman-Weidman syndrome or Wagner syndrome or the Nystad syndrome. So after this, all the differentials and so what is the post-treatment follow-up? So secondary malignancy occur in cases in Wilms tumors and due to abdominal radiotherapy and adjuvant chemotherapy. And these include secondary sarcomas, leukemias, and congestive heart failures. And surveillance is usually is offered to children with increased risk, more than 5% of risk of Wilms tumor. So new Wilms tumor surveillance guideline says that a duration of up to age 7 years and frequency is 3 monthly. They should be monitored by regular ultrasound scans. And metastatic and recurrent disease, metastasis most commonly lung and liver. So most of the time the patient has undergone CECT. So at the time of when you receive the specimen, then only you check whether the CECT has been done or not. And patient who has hematogenous metastatic disease of lung and liver or other areas are classified both in stage 4 disease in both the treatment protocols. And if complete response is observed or lung nodules are completed surgically, so patient do not receive radiotherapy, lung radiotherapy, otherwise they will receive. And for poor respondent, more drug regime is, a 4-drug regime is added. And liver metastasis is similar to lung nodules and treated with chemotherapy and radiotherapy. And recurrent disease is difficult to treat in children with the Wilms tumor with only approximately 50% survival. And most recurrence happens by 18 months. And the tumor bed where the treatment has been done and the lung are the more common types. Prognosis wise, it has got a very good prognosis, approximately 90%, and relapse is about 15%, with that too within 2 years of diagnosis. And there are number of prognostic factors in SIOP and COG protocol. We will see. So in SIOP protocol, there are prognostic factors include the high risk stratification into 3 treatment group, as I told you, low risk, intermediate risk, and high risk. And then the tumor volume before and after the preoperative chemotherapy in defined cases. Responsiveness of lung metastasis to initial therapy, and molecular markers are still not used in prognosticating SIOP. In COG, age, tumor weight, and rapidity of lung metastasis is there. And in molecular marker loss, LOH, loss of heterogeneity at chromosome 1p and 16q, and 1q gain, which has been identified very recently, required for prognostication. So if we have to find the prognosis and give a better treatment to the patient. So what are the things to be done? So we have to knock the door of the biomarkers. So this is the list of diagnostic molecular pathology, or the list of the genes which are there. And as you can see that the insulin growth factor 2 and T53 are approximately 70% prevalence is there, and they are associated with nephrogenic rest with epithelial blastomal histology and associated with anaplasia. So these are the molecular markers, and all these markers can they can co-occur in approximately 1/3 of these Wilms tumors. And also, as I told you, these if we find this loss of heterogeneity involves 1P and 116Q, and correlate positively with a poor prognosis and increased risk of relapse. So if we see this LOH, then it triggers to recommend a modest increase in the chemotherapy and drug regime. So molecular analysis of specific histological subtypes may also be reveal mutation in the gene that may reflect genetic predisposition. For example, WT1 stromal type or predominant tumors are there. So further updates are microRNAs. They can be biological. They are involved in many biological processes like development, growth, and metabolism, and they contribute to development of various kind of tumors. And in WT1, there are many microRNAs which are dysregulated and upregulated and downregulated also. So the upregulated microRNA is Oncomir1, which promotes cell proliferation, and it is upregulated in Wilms tumors as compared with the healthy kidney tissues. And atypical activation of this may contribute to oncogenesis in WT1, this Wilms tumor. Another one microRNA is for 483, 3P, 5P, which is also upregulated in 100% of Wilms tumors, and functional positive feedback loop between this has been suggested, between the IGF2 has been suggested. Other than now we are seeing the upregulated, the downregulated microRNAs are these 204 MEs homobooks 1, which is significantly decrease in all WT1. This Wilms tumor samples compared to with normal renal parenchyma, and 185 also it has an inverse correlation with Wilms tumor and normal matched controlled tissue. Circulating tumor DNA is also required for molecular diagnosis and monitoring of the cancer, and it is since in Wilms tumor, one of the main challenges is intratumoral heterogeneity of the somatic genetic changes. So they may overcome by analysis of circulating tumor DNA. So just 2 cases I want to share. This is one of the case where it's a 4-year male, and this patient was given chemotherapy regime, and this is how we give our report in our institute. And this is how you can record your findings of the gross findings, microscopy, and the final report where you have to write residual Wilms tumor, the type, the risk and viable tumor percentage, and what blastoma percentage, and what is the location, size, its involvement, what is the percentage of necrosis, and LVIP and anaplasia, nephrogenic rest, and adrenal, and all the other structures are there along with lymph nodes. And this again staging also this there. In this the tumor thrombus, I showed you the picture before. There's the same patient. So tumor thrombus was there, but the patient the tumor thrombus from the renal it was there, but it was there in the body also. So we upstaged the tumor to stage 3 rather than stage 2. This is another case of a 10-year-old girl, and where upstage. This is a recent case which I showed you earlier. There was a tumor in the upper pole and the middle part of the kidney, and it was measuring the 6 centimeter in greatest dimension. And this is how we report the microscopy, and in the COG protocol, where you have to just write the type and the favorable histology like that. No risk assessment is given at this level. And presence of anaplasia or not, you have to mention. Nephrogenic rest, you have to mention, and any other all the structures routinely. And again, you have to give the stage at the end of this. So conclusion, histopathological evaluation of Wilms tumor or nephroblastoma is critical aspect in management of the tumor. So pathologist has a very important role to know what are the treatment protocols have been followed. So as the tumor characters are different in both the tumor treated with under SIP and COG protocols, the pathologic factors to be assessed and prognostic risk calculation are also different. This necessitates the knowledge of important prognostic parameters and application of different methods and grossing and reporting of these tumors under these two protocols. Hence, adequate sampling and appropriate reporting for better classification and quantification in both treatment naive and post-chemotherapy is required. This is the meeting at the WHO Center in Lyon, France. We have attended last year, and you can find me here. And where we discussed the 5th edition, what were the changes which was brought in the 5th edition WHO, and what we have to do for the next 6th edition also. And I got my copy of pediatric tumors. This is the first time a WHO book on pediatric tumors have come. It has 2 volumes, and you can find my name as an IARC editor in the 2nd page and as a contributor at the back of the book also. So this is the topic, and I want to thank my institute, my department, my fellows who have helped me for making this PPT, and I want to thank Dr. Nadeem for giving me this opportunity to present. Thank you.